Hello, and thank you for joining us. My name is Jan Johnston. This presentation addresses hospital bed rail entrapment, including benefits and risks of bed rails, entrapment risk factors, and patient safety strategies to reduce the risk of entrapment. It is available on the Pennsylvania Patient Safety Authority's website, which is responsible for the Pennsylvania Patient Safety Reporting System, or PACERS. First, let's define the terms entrapment and hospital bed system. Entrapment involves a patient who is caught, trapped, or entangled in a hospital bed system. A hospital bed system includes spaces in or around the bed rail, the hospital bed mattress, and the hospital bed frame. Entrapment is a serious patient safety issue. During a 20-year period, the U.S. Food and Drug Administration, the FDA, received reports of more than 400 deaths and more than 100 non-fatal injuries caused by bed rail entrapment. Moreover, from June 2004 to December 2006, more than 100 reports were submitted to PACERS involving bed rail entrapment, some involving significant injuries requiring increased hospital stays. In response to reports of entrapment, the FDA partnered with the Veterans Administration, Health Canada, other federal agencies, national healthcare organizations, and other stakeholders to form the Hospital Bed Safety Work Group, or HBSW. In an effort to standardize and clarify the bed entrapment discussion, the FDA and the HBSW defined the 7 areas of the hospital bed system in which patient entrapment is most likely. In Zone 1, a body part becomes entrapped within the bed rail. Zone 2 includes entrapments under the rail and between rail supports or next to a single rail support. Zone 3 includes entrapments between the rail and the mattress. Zone 4 involves entrapments under the rail but at the ends of the rail. In Zone 5, patients become caught between split rails. Zone 6 is the area between the end of the rail and the side edge of a head or footboard. Finally, Zone 7 involves the area between the head or footboard and the end of the mattress. In certain circumstances, bed rails can be beneficial. They can provide convenient access to bed controls, TV remotes, and call buttons. They are also useful in preventing patient falls during transport in a bed or stretcher. Some patients feel more secure and comfortable in an unfamiliar hospital bed when bed rails are raised. Patients can use bed rails to assist getting in or out of bed or to help with turning or repositioning. However, bed rails are also associated with several patient risks, including severe injury, suffocation, strangulation, and even death. Raised rails can inhibit patients' activities of daily living, such as getting to the bathroom or reaching for an object. The restriction of the rails may promote feelings of isolation and imprisonment. Patients may become increasingly agitated in response to both of these risks. Rails in contact with a patient's body part may also increase the risk of skin tears or abrasions. Finally, while bed rails have been perceived as a deterrent to falls, patients may sustain more serious injuries because they are falling from a greater height. Risk factors can be classified into 3 categories: patient-related, care-related, and equipment-related. Regarding patient-related entrapment, bed rail entrapments more commonly occur in frail, elderly, and cognitively impaired patients. Those who are a fall risk may become entrapped in the bed system while getting out of bed unassisted. Incontinent patients or those with acute urinary retention or fecal impaction may attempt to leave the bed in order to toilet. Patients with limited mobility, uncontrolled body movements, or a physical deformity may also be at risk because they may be physically unable to extract themselves from the bed system. those taking sedative or psychoactive drugs may be unaware of entrapment when it occurs. Regarding care-related entrapment, entrapment is more likely to occur when any of the following is not provided on a timely basis: toileting, position changes, pain management, or other interventions to promote the patient's comfort. Delays in such care promote agitation, which can lead to entrapment when the patient attempts to move. Finally, regarding equipment-related entrapment, older bed systems may not have been designed to prevent entrapment. Moreover, entrapment risk may increase as the bed ages and components are replaced. For example, replacements for worn-out hospital mattresses may not fit as snugly as the original mattresses. When a patient moves to one side of some types of air pressure mattresses, that side compresses while the center of the mattress raises. The resulting slide allows the patient to move toward the bed rail. Such compression also may widen the space between the rail and the mattress, increasing entrapment risk. If older bed rails no longer consistently lock into the raised position, patient movement may cause the partially raised rail to fall down onto a patient's neck or extremity. The physical structure of the bed rails may increase entrapment risk. Rails with winged lower edges or those with wide spaces between the vertical bars can be problematic. Many patient safety strategies can be remembered by thinking of the straight A's for entrapment prevention: approach, assessment, awareness, and actions. While bed rails have been used as a safety mechanism for fall prevention, their use may pose a hazard. Rather than automatically applying them, approach the use of bed rails by conducting a risk-benefit analysis. Make bed rail decisions on the basis of individualized patient assessment. Today, many healthcare organizations consider bed rails a restraint. Before automatically raising bed rails, consider evaluating and documenting the rationale for using them. Because bed rails are potentially restrictive devices, ask what kind of surveillance needs to be in place to assure safety when they are used. Assessment strategies include both the patient and equipment. Individualized and ongoing patient assessment involves the interdisciplinary healthcare team, the patient, and family. By obtaining patient information to identify entrapment risk factors and to determine patient routines, healthcare workers also identify patients at fall risk and candidates for restraint use. Equipment assessment involves regular, periodic assessment of bed system entrapment zones. The HBSW has developed a test tool, and the FDA has published dimensional guidelines that plant operations personnel can use to measure certain entrapment zones in full-sized hospital bed systems. While providing direct patient care, healthcare workers are in a prime position to identify when reassessment of bed systems is appropriate, including when bed system components are changed, added, or removed, as well as when components are worn down. Awareness about the risks, risk reduction interventions, and appropriate bed rail use promotes a safer patient environment. Consider encouraging patients and families to learn about the purpose and potential dangers of bed rails and to talk to healthcare workers concerning when bed rails are indicated. Providing a brochure to patients and families concerning bed rail safety. While participating in patient care rounds, discussing entrapment risks and measures to reduce risks. Actions to reduce entrapment risk involve the prescriber, patient care, equipment, documentation, and a hospital bed safety program. The prescriber can reduce entrapment risk by minimizing mental status altering medications or ordering physical therapy to promote safe mobility. Anticipate patient needs by customizing schedules for toileting, positioning, or pain management. Accommodate patients' habits, such as preferred bedtime routines, and incorporate them into the care plan. Consider alternatives to bed rail use, such as placing mats next to the bed, using positioning bars, or providing diversions to reduce agitation. If bed rails must be used, reduce entrapment risk by using bolsters or spacers of firm foam blocks to fill gaps between the mattress and bed rails, or applying bed rail covers. Reports of entrapment that contain complete information will contribute to an entrapment risk reduction program by providing a foundation for comprehensive analysis and effective corrective actions. Thank you for joining us for this presentation. We hope you'll find this information useful in your own facility. For further details on any of the topics discussed in this presentation, refer to the source article, "I'm Stuck and I Can't Get Out, Hospital Bed Entrapment," from the December 2006 Patient Safety Advisory. This presentation was developed as part of the Pennsylvania Patient Safety Reporting System. To learn more about PASERS and to find information on other topics, visit the Patient Safety Authority website at www.psa.state.pa.us.